After doing iron deficiency anemia, let's talk about hemolytic anemia now. Another very important part of this anemia lecture series. Now, what is the meaning of hemolytic anemia? In this condition, the RBCs are destroyed rapidly than the synthesis. So see there, the bone marrow is doing good job here. The bone marrow is trying to synthesize more RBC, which is known as erythropoiesis. But at the same time, the destruction rate is more than the synthesis rate. So hemolytic anemia are the anemias due to increased red cell destruction, which is coupled with increased erythropoiesis. But that erythropoiesis is not enough for the normal number of RBC. Now, all of you, please focus on this slide. What can you see here? Yes. What is the interpretation of this slide? Anyone in this picture? What are
It looks
shown?
like
There's red cell increase.
sir, irregular shaped, and sir, we have got irregular sized RBC in here, sir.
Okay. So see that there are different shape of the RBC. You can clearly see. Look at this shape here. Okay. Different shape and different sizes. Some are smaller, some are bigger, some are in between. So this is called poikilocytosis and anisocytosis. We already talked about poikilocytosis and anisocytosis. One more, they are of different color. Some are completely, full of the color. See that? Some I can see central pallor. So this is known as polychromasia. Polychromasia. So anisocytosis, poikilocytosis, polychromasia. These are the hallmark feature of hemolytic anemia in peripheral smear. Let's move on. Now, in the beginning, let's talk about the classification of hemolytic anemia, or you can call them causes of hemolytic anemia as well. So what are those? So they are either cellular defect or intracorpuscular defect or extracellular defect or extracorpuscular defect, whatever way you want to say. So the first is membrane defect, and among them hereditary spherocytosis and hereditary elliptocytosis are the good example. Under enzyme deficiency, we have pyruvate kinase deficiency and glucose 6-phosphate dehydrogenase deficiency, also known as G6PD deficiency. And among the hemoglobinopathy, we have abnormal hemoglobin, okay, like hemoglobin S, also known as sickle cell hemoglobin or hemoglobin E. And another is a defective synthesis, that is thalassemia. So we are going to talk some of this topic in detail, only the important one, and other I'll give a bit of concept for you. Now, the second type of hemolytic anemia are because of extracellular defect. Because of extracellular defect. Now see there, what are those? Immune hemolytic anemia. They are either autoimmune, okay, or because of hemolytic disease of the newborn or transfusion reaction. These are also known as alloimmune. Alloimmune. Okay. Now, why alloimmune problem? Because the antibody developed by the mother is going to the newborn. Okay. And here, though the antibodies are present in the patient, but the antigen are entering from outside. That's why they are not written in the autoimmune variety. Warm and cold antibodies may be there. Warm antibody, they react in warm temperature, like 37 degrees centigrade. And cold antibody, they react around 4 degree centigrade temperature. That's why the name given. Okay. Cold antibodies are present in certain infective and certain, other conditions. One of the common infection is mycoplasma infection. Mycoplasma infection for the cold antibody synthesis. And they may also be present in certain non-Hodgkin's lymphoma and certain other myeloproliferative disorders. I'm providing a little bit more knowledge for you here. Fragmentation hemolysis, also known as microangiopathic hemolytic anemia. Now, we have talked about this during the general classification of anemia. They may be disseminated intravascular coagulation. They may be hemolytic uremic syndrome. They may be thrombocytopenic purpura, or they may be prosthetic valve. Prosthetic valve means artificial valve which is there in the patient after the replacement. In this condition, one of the common mechanism is the RBC surface membrane is damaged and those RBCs are removed from the circulation. Another important cause is hypersplenism. Now, the meaning is spleen is overactive or hyperactive in this condition. Usually, the spleen is bigger in size, okay? And apart from the size, which is bigger, the spleen is over-functioning. Now, if your teacher asks what are the causes of hypersplenism, then you can answer very confidently. Okay, the causes of big splenomegaly or huge splenomegaly, like portal hypertension, malaria, Kala-Azar, chronic myeloid leukemia, okay, even lipid storage disorder. So all of these can be, listed here. One very important point, along with pancytopenia, the hypersplenism patient are having erythroid hyperplasia in the bone marrow. So let me highlight these two important points here for you. So they have pancytopenia because that hyperfunctioning spleen will consume the normal cells, and when we do the bone marrow aspiration, there will be erythroid hyperplasia. These two things together will give us a very easy diagnosis of hypersplenism. Some other causes of hemolytic anemia from the extracellular defect are Wilson disease. Okay. Wilson disease. What is Wilson disease? Anyone?
Sir, in beta,
Excess
sir,
copper stored in
Copper
stored in different organ like
body tissues
liver,
like liver,
eyes,
and sir, and sir, it
kidneys,
is
that lead
rise
to
in the case of
the
pleasure.
coming out the eyes,
that may
Okay.
cause the liver
hepatic
hepatitis.
diseases.
Exactly. From the next time, whoever want to answer, I'm not discouraging you guys, okay? I love my students to answer, but please tell me, sir, can I answer like that? Then it will be better because sometimes when multiple students speak at the same time, I cannot hear anything, okay? So please do that. That would be better. And you can wait for your turn also. Now, Wilson disease, you are absolutely right. It is a copper overload condition. It's a copper. There is too much copper in the body, and that copper, okay, copper is a type of heavy metal, so it can damage the surface membrane of the RBC, resulting in hemolysis there. Infections like malaria, very important cause of hemolysis. No, analysis or description necessary there. And bacterial sepsis or any septicemia can also result in hemolysis. So this is a very, easy type of classification for you. Let's move on. Now, this slide is absolutely important. So I want my student, please pay attention here. Okay, this will give you an overall concept how to diagnose hemolytic anemia. Now, regarding the diagnosis of hemolytic anemia, we have got two parts here. One is evidence of red cell destruction. Another is evidence of red cell generation. I have told that multiple times, bone marrow is functioning well in case of hemolytic anemia. We need to prove that as one of the wing of the diagnosis. Another is we have to confirm there is excessive red cell destruction at the same time. Now see here. So these are the evidences of red cell destruction. They are while doing the peripheral blood smear, if the cells are fragmented, if they are Burr cell, Burr means there are spicules present on the surface. Okay, small spikes are coming out from the surface, and if they are teardrop cells, means they are of different shape. Okay, they are of different shape, and this is one of the feature of RBC destruction. If the free plasma haptoglobin is decreased, haptoglobin is the carrier molecule or protein for free hemoglobin. Now listen again, haptoglobin is the carrier protein for free hemoglobin. Now see what is happening for the free hemoglobin here. It is increase in case of hemolysis because RBCs are destroyed, hemoglobin will be released outside and that free hemoglobin will be increased in the blood. This haptoglobin will bind with this free hemoglobin so that the level of free plasma haptoglobin is decreased. We can consider this as an important feature of hemolytic anemia. Lactate dehydrogenase enzyme is increased. This is a very non-specific enzyme which is present inside the tissues or cells. In this condition, we are talking about RBC. If RBCs are damaged or destroyed, then LDH level will be high. Alone, it may not tell you anything, but in the combination of other features, this is an important diagnostic point. Indirect bilirubin is increased. Now, every student knows this mechanism. Bilirubin synthesis occurs from the heme. Heme is a part of hemoglobin. Okay, hemoglobin is present inside the RBC. Now look at the connection there. This is a hemolytic anemia, means RBCs are getting destroyed. So heme is released. Heme will undergo into bilirubin pathway and bilirubin is formed. This bilirubin is an indirect type of bilirubin, means unconjugated type of bilirubin, which is high in the serum. And if we can utilize this, during the investigation, it is also telling us, okay, yes, this may be a case of hemolytic anemia. The level of bilirubin is not that high in case of hemolytic anemia. Now, another wing of the diagnosis is evidence of red cell generation, and that is done by increased reticulocyte count. Okay, we already talked about this. Normally, the reticulocyte count is less than 2%. 1 to 2% is the normal one. If it is more than 2%, that is high reticulocyte count. It indirectly tells us bone marrow is hyperfunctioning, and this may be a case of hemolytic anemia. Another one, polychromasia and presence of nucleated red cell on peripheral smear. That is another evidence. Means bone marrow is forming too much or too many red cells, and before they are mature enough, they are coming in the peripheral circulation. Third one, though it is not written here, if you do bone marrow aspiration or bone marrow biopsy, you will see a lot of erythroid progenitor cell in the bone marrow. This is known as erythroid hyperplasia. But why we usually do not go for this? Because this is an invasive test. Okay, we need to do the aspiration of the bone marrow. This is a painful procedure. If we can diagnose hemolytic anemia because of this, why you need painful procedure? So this is the discussion about the confirmation of hemolytic anemia. Now, another part is still there. Which type of hemolytic anemia is this? There are so many. Is it thalassemia? Is this sickle cell anemia? Is this G6PD deficiency? Is this autoimmune hemolytic anemia? Is this hereditary spherocytosis? How to confirm that? We still need to do certain other tests. So these are called, for underlying cause of hemolysis, these tests are done. Now see here. Regarding the confirmation of the underlying cause, peripheral blood smear helps us a lot. Spherocytes are seen in hereditary spherocytosis. Sickle cells are seen in sickle cell anemia. Okay, very easy. Acanthocytes are seen in A-beta lipoproteinemia. See that? A-beta lipoproteinemia. The lipoproteins are absent from the blood. And this acanthocyte is a protoplasmic projection, giving it a thorny appearance. Okay? A spike-like, projections are seen on the surface of the RBC. These are called acanthocyte. This is a very important MCQ question which may be asked in your exam. Please remember, acanthocyte, A-beta lipoproteinemia. And malarial parasite can also be seen in case of malaria. Malarial parasite, okay, or plasmodium, different types of plasmodium can be seen inside the RBC. Osmotic fragility test of RBC is done for the diagnosis of hereditary spherocytosis. And in this situation, we just dilute the normal saline, or we can, put those RBC in 0.45% normal saline, means half diluted normal saline. And these RBCs are ruptured far, far earlier than the normal RBC. This is known as osmotic fragility test. Another is a direct Coombs test, which is present in autoimmune hemolytic anemia. We can also go for indirect Coombs test here. There is one small difference between direct and indirect Coombs test. Direct Coombs test means the autoantibody, okay, is fixed on the surface of RBC, whereas indirect Coombs test is all about free antibody present. Regarding the diagnosis of G6PD deficiency and pyruvate kinase deficiency, you can go for enzyme assays. What is the level of enzyme in the RBC? And regarding the diagnosis of thalassemia and hemoglobinopathies, you can go for hemoglobin electrophoresis, like sickle cell anemia and beta thalassemia. Electrophoresis is a wonderful way of diagnosing them. Okay, now you already got the concept how to diagnose hemolytic anemia. Look at some of the peripheral smear slide now. So see this. These are the spherocytes. Spherocytes mean they are spherical in shape, mean they are more rounded than the normal RBC. Okay, that's why they are known as spherocyte. And these spherocytes are usually smaller than the normal RBC. So these are spherocyte. These are called ovalocyte. Ovalocyte. Sometimes RBCs are like that, and this is known as ovalocytosis. This is one type of hemolytic anemia, and these are the different shape of the RBC. This is known as acanthocyte. Look at this one. These are acanthocyte. You can see some spicules coming from the surface of the RBC. Okay, here is another one. Here is it's going to develop like that. Here is another one. So these are called acanthocyte. And acanthocytes are seen in which disorder? Just now we talked about that. Which disorder is this? Yes?
A-beta lipoproteinemia.
A-beta lipoproteinemia.
Excellent. Very good. A-beta lipoproteinemia. Very nice. Now, this is polychromasia. Polychromasia means on the same slide or same field, there are different color of the RBC. You see this. This number 1 is increased color of the RBC. Now number 3 is having the central pallor, okay, and number 2 is probably in between. So this is known as polychromasia, one of the hallmark of hemolytic anemia. Now with this discussion, let me start a very important topic under hemolytic anemia, that is diseases of abnormal hemoglobin. And I'm going to talk about 2 important conditions here. One is sickle cell anemia, another is thalassemia. Now, see there, hemoglobin is the most efficient oxygen carrier known. There's no doubt about it. This is the function of hemoglobin. It has the unique property of combining reversibly with oxygen. This combination has to be reversible. If hemoglobin only binds with the oxygen but doesn't want to give oxygen to the tissues, what is the use of that hemoglobin? Okay, so it is no use for our tissues. Now, I want to take 2 names immediately here: fetal hemoglobin and hemoglobin A, or adult hemoglobin. Fetal hemoglobin will bind with oxygen very readily. Okay, means quite actively, you can talk like that. But when it is time to give that oxygen to the tissue, it doesn't want to give. Whereas adult hemoglobin or hemoglobin A will bind with the oxygen also, though the affinity of that hemoglobin towards the oxygen is slightly lesser than fetal hemoglobin, but It has another very important property. It will give the oxygen readily to the tissues. That's why we like to have adult hemoglobin in our blood. Okay, it takes time for the switching of that hemoglobin after the baby is born. After 6 months, okay, the percentage of fetal hemoglobin is very, very less in the child. Now, this is the function of hemoglobin. It takes up oxygen as the blood passes through the lung and releases it as the blood passes through the tissue. Okay, and vice versa is also true. In the tissue, it will bind with carbon dioxide, and that carbon dioxide is given, okay, inside the lung, and carbon dioxide is exhaled outside. This is also done by hemoglobin. So you can see here, this is a very basic, function of hemoglobin. We already know that. Now, what type of, molecule is hemoglobin? What is there? What is the composition of hemoglobin? Okay, let's talk a little bit about it. A hemoglobin molecule consists of a porphyrin ring with a central iron atom, which is known as heme. This heme is a porphyrin ring and iron is attached there. It is hooked to a clump of protein known as globin. That's why hemoglobin, heme and globin together is called hemoglobin. Now in the heme, there is attachment of the iron, and globin is polypeptide chain. Now look at this structure. So this is heme, okay? This part is heme, and these other things are globin. Oxygen is always bind to heme. Now another important point for us, the polypeptide chain which is present in hemoglobin are chemically different according to the different types of hemoglobin we have. Now all of you please focus on this graph here. See here, it is written gestational age, this is the time of birth, and this is the postnatal age. This is the postnatal age, means after the birth. And this is the percentage of total hemoglobin in the blood. Now, let's talk about adult hemoglobin first. Okay, adult hemoglobin first. Adult hemoglobin has 2 alpha and 2 beta. Now, alpha chain is common in all of them. Okay, alpha chain is present in all of them. So this is alpha chain. You can clearly see this red line, a red graph, alpha. It is present in every different types of hemoglobin. And this is a beta. Look at the percentage of beta according to the age group. In the intrauterine life, the percentage of beta chain is not that much. At the time of birth, okay, it is increasing. And see there, at the 6 month of age, it is very much increased. And then it will take over completely as other forms of polypeptide chain in globin chains are very severely decreased. So look at the gamma chain now. This is a part of fetal hemoglobin. So inside the intrauterine or fetal life, it is so high, but after the baby is born, it gradually decreases and become very, very less. Okay, so these are some of the very important knowledge. Now with this, let's talk about what are these different types of hemoglobin and what are the different types of globin chain. Important questions from the exam point of view again. We have got embryogenic period, we have got fetal period, and we have got adult period or adult life. Embryogenic life, fetal life, and adult life. Okay, so inside the embryogenic life, up to 8 weeks, you can say, that is called embryo. From the time of fertilization up to 8 weeks is the embryogenic period. So we have hemoglobin Gower 1, hemoglobin Gower 2, and hemoglobin Portland or Portland hemoglobin. These are the different names of the hemoglobin during that time. And these are the different beta chain, globin chain present. Okay, globin chain present. This is zeta and this is epsilon. This is alpha and this is epsilon. Okay, This is epsilon and this is gamma. So nobody is going to ask you about embryogenic hemoglobin because it doesn't have that important clinical role here. Okay. Whereas these fetal and adult hemoglobins are very commonly asked in the exam. So every student must remember them. Like fetal hemoglobin, hemoglobin F has 2 alpha and 2 gamma chain. And adult hemoglobin are of two types, hemoglobin A and A2. Hemoglobin A has 2 alpha and 2 beta, whereas hemoglobin A2 has 2 alpha and 2 delta. Okay, now these are the period when it is maximum present. Now, this slide is telling us about which chromosome is responsible for the synthesis of these different types of, globin chain, different types of globin chain. See there, chromosome number 11 is responsible for gamma chain, delta chain, and beta chain synthesis. Means the gene which are responsible for the coding of these proteins are present in chromosome number 11. Whereas chromosome number 16 is responsible for the synthesis of alpha globin chain. This is another important question which can be asked in MCQ paper. 16 is for alpha only, 11 is for rest of the others. Okay, I'm making it very easy for you. So 2 alpha, 2 beta, this is hemoglobin A. 2 alpha, 2 gamma, hemoglobin F. 2 alpha, 2 delta, hemoglobin A2. So the percentage of this hemoglobin in an older child or in adult is this one. 97% of the hemoglobin is hemoglobin A, 1% is hemoglobin F, and 2% is hemoglobin A2. In the normal person I'm talking about, right? So, but in case of beta thalassemia major, remember beta thalassemia major, where hemoglobin A is not formed at all, what will happen now? Hemoglobin F is in the excessive amount and hemoglobin A2 is also increased. So this is a small clinical correlation. So this slide is again telling us the different types of hemoglobin and what globin chains are present in them. So let's quickly go through them. These are the types of hemoglobin we have. See that hemoglobin A, hemoglobin F, hemoglobin A2. These are the names of the globin chain. So 2 alpha, 2 beta in hemoglobin A, 2 alpha, 2 gamma, hemoglobin F, 2 alpha, 2 delta, hemoglobin A2. You need to remember this. This is the normal percentage at birth. At the time of birth, hemoglobin A is already around 20%. But the majority of the hemoglobin, see there, is hemoglobin F at the time of birth. Whereas hemoglobin A2 is less than 1. Normal percentage in older children, hemoglobin A 98%, hemoglobin F less than 1, hemoglobin A2 less than 2. This is definitely reached more than 1 year age group. From 6 months, the fetal hemoglobin is less than 5%, but after the 1 year, it is even less than 1%, almost like adult. And there is a small clinical correlation now. This is alteration in disease. See that hemoglobin F is very high in beta chain hemoglobinopathies. This is known as beta thalassemia major. Whereas hemoglobin A2 is also high in beta thalassemia major, okay, a beta thalassemia trait, and they are decreasing alpha thalassemia. Why are they decreasing alpha thalassemia? Anybody can tell me why? Anybody who is ready? Yes. This is a difficult question. Okay, so let me answer this because nothing is coming from that side. So alpha thalassemia means there is no alpha chain. Remember, all of these hemoglobin have alpha chain. See this, 2 alpha, 2 alpha, and 2 alpha. So all different types of globin chain will be severely decreased in alpha thalassemia. All, okay, even hemoglobin A is decreased there. Hemoglobin F, hemoglobin A2, everything is decreased. So this is a very difficult type of situation. Now, with this discussion, let's enter into the, topic of abnormal hemoglobin. We'll talk about a bit of pathological aspect here. Why abnormal hemoglobins are formed or synthesized? This is the first question here. Okay, you see this? There is point mutation and deletion in the hemoglobin gene here. Point mutation and deletion in the hemoglobin gene. What does that mean? What is mutation? Anybody? Mutation means what?
Sir,
Normal
sir, when the gene sequence is reversed, so some changes in the gene
Mutation
sequence.
is sudden change in DNA.
Exactly. Absolutely. All of you are right there. Mutation is there is certain sequence, okay, certain order in the gene. Different, nucleotides are ordered in a, absolutely right way there. If that is changed or, sometimes they are deleted, sometimes they are replaced by something else, and that is known as mutation. And mutation will cause opposite effect or, altered effect or function of that particular gene. Now, see what is happening here. Point mutation and deletion in the hemoglobin gene, which results in structural change in the hemoglobin molecule, which results in change in function of the hemoglobin. Now, they can be of two types: qualitative defect. A good example is sickle cell anemia, and quantitative defect is thalassemia. The overall quantity of the hemoglobin itself is very less in thalassemia, whereas in sickle cell anemia, the quality of that hemoglobin is altered, means hemoglobin A will be converted into hemoglobin S. This is a change in quality. Whereas in thalassemia, the hemoglobin A, okay, is decreasingly formed. It is very, very reduced. So that's why it is known as quantitative defect. Now with this concept, let's enter into the topic of sickle cell anemia. So we'll just, talk about some important aspect today, and in my next lecture, we'll continue that. What is a problem in sickle cell anemia first? Now see there, okay? This is a very important concept, so I want all students to please focus here. There is a base pair change. That means, okay, thymine is replacing adenine at 6th codon of beta gene. 6th codon of beta gene. Now, where is beta gene present? In which chromosome beta gene is present? Which chromosome is that?
Chromosome number 11.
Chromosome number 11.
Very good. Chromosome number 11. Absolutely. So, in that chromosome number 11, some changes are developing here. This is the point I'm talking now. So, glutamic acid, okay, is replaced by valine. Glutamic acid is replaced by valine. This alters the charge at the site. What does that mean? Because of this replacement, some altered type of hemoglobin is formed, which is known as sickle cell hemoglobin. And when that sickle cell hemoglobin passes through the hypoxic environment, there is polymerization develop. Means multiple these RBC will stick with each other. This is known as formation of polymerization. Now they will block the very small circulation. The smallest circulation in our body are called capillaries. So they will block those capillaries, resulting in hypoxia, resulting in thrombus formation. This is also known as thrombotic coagulopathy. This is the main mechanism in sickle cell anemia. Now, let me repeat again, because this glutamic acid is replaced by valine, which alters charge at the site, means there is alteration in charge regarding the hemoglobin synthesis, which is known as sickle cell hemoglobin. They stick with each other unnecessarily, especially in hypoxic environment, which results in all the clinical features of sickle cell anemia. Let's move on. The disease state is known as homozygous state. I already told you this is a homozygous state, also known as homozygous SS. Okay, hemolytic anemia occurs within the first 2 to 4 months in this case. See that, and hemoglobin F is replaced by hemoglobin S. Now, in the normal, baby, hemoglobin F is replaced by hemoglobin A, but this is a hemoglobinopathy we are talking about. So abnormal hemoglobin will replace hemoglobin F here. And after that, okay, the child may manifest, especially if the child is having certain infection or hypoxia or dehydration. Remember these three important point here. These are called precipitating factors for the polymerization. So infection can easily lead to acidotic environment. Hypoxia can also lead to acidosis, and dehydration can also lead to acidotic environment. So acidosis is written here. Okay, so let me write this important thing for you so that you don't forget. Infections, hypoxia, and dehydration. These three are the important points. So we should always take the good history regarding this. Now, another important point, which are the other factors which affect polymerization, that is increase hemoglobin concentration. Increase hemoglobin concentration. That is known as increased hematocrit. And especially if hematocrit is more than 30%, if it is more than 30%, then there is a high chance of polymerization. Okay, it is always 30%, then there is a high chance of polymerization. Now see that. Now what happens in case of dehydration regarding the hemoglobin concentration? What happens in dehydration? Anyone? What dehydration is doing regarding the hemoglobin concentration? Anybody?
The plasma volume decrease and hemoglobin volume increase. That's why it lead to polymerization.
Okay, good. Yes, another student also trying to say, please go.
Sir, because of the loss of water, sir, relatively, sir, the hemoglobin will increase.
Very good, very good. Yes, Uzair, good. Yes.
So basically, so like if the patient is normovolemic, so then if sir is severely dehydrated, so basically the hemoglobin and the hematocrit both will be increased, sir, in that case.
Exactly. All of you, okay, all of you are answering exactly, correctly. Hemoglobin concentration increases. This is known as hemoconcentration because of, decrease in plasma volume. There is relative increase in hemoglobin or RBC concentration, and that doesn't help this process. The polymerization further increases. That's what I want to say here. Now, let's move further. This is a very, very important point. 95% of the children develop functional asplenia by 5 years of age. By the time they reach 5 years of age, 95% of them have already lost the function of the spleen. This is known as functional asplenia, or it is also known as autosplenectomy. Autosplenectomy. This is a very useful term to remember. The spleen is there, but it looks like the spleen has been removed. What does that mean? The spleen has lost all its function, and we all know what are the functions of the spleen. One of the main function of the spleen is immunological function. Whatever capsulated organisms are present in the blood, spleen will filter them and remove them. Okay, remember this all the time. Another is, after the RBCs have completed their lifespan, those RBCs are also removed by the spleen. Okay, so many other functions are there. Antibody synthesis occurs in the spleen, different things. So if spleen function is lost, okay, that child has a major risk of infection. Okay, So that is one of the major problem in case of sickle cell anemia. Now, what are the clinical problems in that child? Let's talk one by one. Or what are the clinical features of sickle cell anemia? If this question is asked, you can easily write like this. Hand-foot syndrome or acute sickle dactylitis in infancy. Now, this means painful, usually symmetrical swelling of hands and feet. This dactylitis means finger. Okay. If fingers are swollen, we call it dactylitis. So there is a painful, symmetrical swelling of hands and feet. Both fingers and toes are affected. Due to decreased blood supply to small bones and by rapidly expanding bone marrow, these are the problems which happen. So this is the mechanism of this problem they're explaining. Now see that why there is decreased blood supply, we all know, because of the blockage of those small capillary by those RBC, polymerized RBC, deformed type of RBC. They lose their flexibility, so they can block those small capillaries. And to compensate for that, remember this is a hemolytic type of anemia, so bone marrow is over functioning, so there is an expansion of the bone marrow, and all of these mechanisms will cause painful symmetrical swelling of hands and feet. Let's move on. Another is called acute painful crisis. Acute painful crisis. What does that mean? See here. In young children, it also involves the extremity, okay? And time and again, whenever the precipitation is done by fever or infection, hypoxia or acidotic environment like dehydration, then there is acute painful episode which involves the extremity, especially in children. And older patient, they have problem in the head, chest, abdomen, and back. Now the mechanism is again the same. It is again caused by blockage of those smaller blood vessels which supply this area. So this is a ischemic type of pain. Another important clinical feature are vaso-occlusive event in different parts of the body. See this vaso-occlusive event, blockage of the blood vessels. It may cause infarction of bone marrow or bone. Again, pain will be there. It may cause splenic infarct, and this is the reason for autosplenectomy. The spleen is already infarcted, in different areas. So overall, the function of the spleen is severely lost. There may be pulmonary infarction, which is known as acute chest syndrome. Mechanism is again the same. The blood vessels which supply some particular parts of the chest or lungs are occluded, so they suffer from infarction. Stroke can happen when there is thrombosis in our cerebral circulation. Stroke can occur. It is considered as one of the major complications of sickle cell disease. In the kidney, we have renal papillary necrosis. Now remember, papilla, okay? Papilla are a part inside the kidney, especially in the medulla, the medullary part. So, to be precise, the junction of the cortex and the medulla. So these papillary area are get necrosed again because of the ischemia and priapism. Now, what is priapism? Anyone?
Sir, may I explain it?
Painful erection.
Okay.
Sir, basically, sir, priapism is a prolonged erection of the penis. Sir, basically, it is in the male, sir, and sir, it is continued for hours, even without any sexual stimulation.
Okay.
And it's
so,
very painful erection of the penis.
Very good, very good. Okay, so I got the answers already. Excellent. Everybody is answering exactly in the same way. This priapism or priapism, whatever you say, is the sustained, prolonged erection of the penis. Of course, in case of boys or male. Now, this occurs because of the obstruction of blood flow there. Remember, for the erection of the penis, okay, some erectile tissues are there, and that should be filled by the blood. Now, they are filled by the blood, but they cannot, okay, the blood is not draining back because of the obstruction, and that is the cause for priapism. Now, sustained priapism can lead to impotence later on. So we need to, tackle this situation in time, and the treatment is, a little bit difficult here. We need to aspirate that engorged, blood by different injections. Okay, different needles. The needles will be inserted there, and that ingurged blood has to be removed if it is prolonged. If it is getting back in time, nothing has to be done. Let's move on. Now, another important part of this lecture, what are the common complications during the first 5 years of life? We are talking about the pediatrics now, and these are the very important questions for you. Now, because of the sickle cell disease or sickle cell anemia, what are the common complications during the first 5 years of life? Now, see there. Bacterial sepsis is one of the main feature here. Now, you all know the reason. Because of the loss of splenic function, there is severe chances of bacterial sepsis. And the common organism for this bacterial sepsis are capsulated bacteria like pneumococci, okay, pneumococci, meningococci, okay, meningococci, and Haemophilus influenza type B, HIB. These are the 3 major organisms which leads to sepsis in these children. Now, what is the message you have got? Either we need to give them antibiotic prophylaxis after they are having this disorder or after we diagnose it, or we should provide them vaccination. Another is acute chest syndrome. Acute chest syndrome, already talked about. Acute chest syndrome means there is pulmonary infarction development because of the blockage of the capillaries inside the lung. And this child develops acute chest pain and cough along with breathlessness and the hypoxic episode as well. Another is splenic or hepatic infarction. Not only spleen, liver can also be infarcted. Different areas, patchy type of infarction. Parvovirus B19 infection can occur, and we use the term aplastic crisis for that. But this is a bit of misnomer for you. Now, why this is a misnomer? Because it only affects the RBC series. Okay, only RBC series are affected here, not the WBC series. Now, having said that, the cells which are developing into the RBC, like the erythroid series we say, are severely suppressed by this parvovirus B19. This is a type of DNA virus. So the child is already anemic because of sickle cell anemia. On top of that, because of this parvovirus B19 infection, the child will become severely anemic. Severely anemic. And the treatment is blood transfusion. This viral infection doesn't last there longer. Okay, it will disappear after a certain time. So we should save the child from the effect of anemia during that period. Okay, so this is known as aplastic crisis. It doesn't only occur in sickle cell anemia, remember, it can occur in any type of hemolytic anemia. Now, another problem is vaso-occlusive episode, and we talked about this already. It can happen in any part of the body, in the hands and feet. Okay, that is a very important site where there is a frequent painful episode, swellings, pain, okay, ischemia, and all these things are happening. Now, these are the predictors of severe course of sickle cell anemia, and these are anemia, painful episodes, and dactylitis before 24 months or before 2 years of age. If the child suffers from anemia, painful episode, and dactylitis, okay, dactylitis is involvement of the fingers and toes, before 2 years, that means this child will have severe course in the future. Okay, this is a severe type of manifestation, and definitely this is a homozygous state. Let's move on. Now, what are the other complications? Later on, some complication can happen. What are those? Salmonella osteomyelitis. Now, this is a very important question you may be asked in the exam. Osteomyelitis is the infection of bone along with bone marrow, and the commonest organism is Staphylococcus aureus. But If somebody is suffering from sickle cell disease, salmonella can be the important causative agent. Skin ulcers these are ischemic type of ulcer. Ischemia can result in breakdown of the skin, resulting in ulceration. The child may suffer from chronic renal failure, CRF. Okay, almost 12% of the adolescent by the time there is that age group already develop chronic renal failure. Now, why is this? This is because of involvement of the kidney. Remember, there is involvement of the papilla of the kidney. Papillary necrosis is quite common in sickle cell disease. So this may be the manifestation over a period of time. Retinopathy occurs. This is involvement of the retina. Again, because of thrombus formation, because of occlusion. A vascular necrosis of the hip, another important complication. This is again because of decreased blood flow, especially of the femoral head. Femoral head. Now remember, hip joint is formed by, which bones are forming hip joint? Who can answer this? Which bones? Which two bones are there in the hip joint?
Sir, basically, sir, it is formed by the head of the femur, sir, and by the acetabulum of pelvis.
You're absolutely right. Okay, absolutely. These are the two bones. This is a ball and socket type of joint. Ball and socket type of joint. It's a synovial joint. So the ball part is formed by femoral head, and the socket part is formed by acetabulum. Now let's come to the point here. Because of blockage of those blood vessels which supply femoral head, the femoral head may become necrosed. This is known as a vascular necrosis of femoral head or hip. Okay, and what happens now? There will be pain in that region. That femoral head will collapse now because of because it dies already, so it collapses, and the hip joint will become unstable. That's the first thing. Second, over a period of time, there will be development of osteoarthritis. This is known as degenerative disease of the joint, and that joint will be painful forever. Okay, and the treatment is in the early period we can do some bone grafting and things like that, but later on when it is an advanced case of vascular necrosis, we have to replace the joint, either hemiarthroplasty or total arthroplasty. Now, another important complication is cholelithiasis. What is the definition? What is the meaning of cholelithiasis?
Sir, formation of gallstones, mainly, sir.
Exactly. Every student knows this.
Gallstone.
Exactly. You have already learned this in pathology. Cholelithiasis is gallstone formation. Now, there are three types of gallstone we have studied. One is called cholesterol stone, second is called pigment stone, and third, mixed type of stone. You can simply say two types, okay? Forget about the third for the time being. So out of these two, cholesterol or pigment stone, which is the stone which is formed here? Which one? Yes, quickly.
But mainly, sir, bile stone, pigmented stone.
Yes, you're right. This is a pigmented stone. Okay, the answer is straightforward. This is a pigmented type of stone, and this pigmented stone is contributed by bilirubin. Now, remember, this is a hemolytic anemia. So bilirubin will be formed excessively, unconjugated bilirubin, and that is causing this pigment type of stone. So these are the important questions for you in the exam. Okay, let's move on. Now, how we confirm the diagnosis? What are the investigation we like to do in case of sickle cell anemia? We always start with CBC because this is an easier thing to do and a very important also. So in CBC, I've only included the important points here. See this? Hemoglobin maybe 5 to 9 gram, but it may be lesser than that. Okay, it may be lesser than that. This is just the common things which I have mentioned here. So already 5 hemoglobin is a severe anemia, and 9 is somewhere mild to moderate. What about the total leukocyte count and differential leukocyte count? Total leukocyte count usually ranges between 12,000 to 20,000. This is because of infection. There is a high chance of infection in this condition as a result of decreased immune function, especially of the spleen. And among them, neutrophil count will be higher if the bacterial sepsis is there. Okay. If other type of infection occur, then this neutrophil count may be normal, but there may be lymphocytosis or things like that. It depends on the situation. The reticulocyte count is always done in case of hemolytic anemia. And look at the reading here. It may be 5 to 15%, definitely more than 2%. Up to 2% is normal. Hemolytic anemia has more than 2% of the reticulocyte count. This is considered as one of the diagnostic feature of hemolysis. And the reason for increased reticulocyte count is because of the hyperactivity of the bone marrow. Okay, in the periphery, the RBCs are broken down because they are abnormal. They are sickle cell RBC, so they are broken down. But in the central area, that is bone marrow, it's trying to synthesize more RBC. That's why retics count is higher. Now, peripheral smear is another part of the investigation. If we do, we can see target cells, we can see poikilocytes, hypochromasia, presence of sickle cell, and even nucleated RBC. Okay, so these are the different types of morphology of the RBC. Now, target cells, okay, it looks like a target at the center. Okay, a bit of target shaped structure is formed at the center. These are abnormal type RBC. These are called inclusion bodies actually. Poikilocyte, different shape. Hypochromasia, different color. Sickle cell, hypochromasia or polychromasia can also be there. Polychromasia, because a hemolytic anemia is usually manifested like that. Sickle cell is the most important feature among them all, which will give us the diagnosis. And a nucleated RBC can be there because of overactivity of the bone marrow. Hemoglobin electrophoresis will give us the confirmatory diagnosis. Now, one important question we love to ask to our student. We give them different options and we ask, what is the most important investigation you will choose, which will give you the diagnosis? And the answer here is hemoglobin electrophoresis. Yes, we do all of them. But what is the question? You need to listen properly. The question is about which is the most important investigation. And that has to be hemoglobin electrophoresis here. Now look at this slide. Okay, what can you see? Look at this RBC here. This is called sickle-shaped RBC. Here is another one. Okay, here is another one. It is converting into this. See this. So these are the different, and look at the shape. The shapes are different. The sizes are different. The color are different. Very typical picture of sickle cell anemia. Now, let's talk about how to manage this case. Okay, what is the management? A very important part of this lecture. The management is divided into a general management, okay, and definitive management. Now, let's talk one after other. Pain management comes under, general management itself. We need to immunize the child with conjugate pneumococcal vaccination and other routine vaccines. Now, what is conjugate vaccine? I like to ask that question. What is conjugate vaccine? Anybody?
Sir, it's a combination of one or two vaccine for pathogens, same like DPT.
Okay.
So
Okay.
basically, it's a combination of weak and
Basically,
strong antigen.
we combine different vaccines.
Good.
So, sir, in vaccine is giving us the probability from decreasing of different diseases. Like, say, for example, MMR.
Okay. Now, listen here. Okay. You have a bit of forgotten the definition of conjugate vaccine, which we have done already in the immunization topic. Now, pneumococcal vaccines are of two types. One is called polysaccharide vaccine and another is a conjugate vaccine. Now, when we mix protein, okay, when we mix protein to that polysaccharide component, then it is called conjugate vaccine. It is not like a mixture of the other vaccines there. Especially in case of pneumococcal and meningococcal vaccine, we use the term conjugate vaccine. That means a protein component is added to the polysaccharide, component of the vaccine. Now, why? That is the big question you need to answer. Because if we add protein, that protein is identified, okay, by our T cells, okay, by our T cells, especially the T helper one, and it will help to form the prolonged immunity there. The memory cells will be formed because of this mechanism. That's why we give conjugate pneumococcal vaccine in case of children, and for the adult, we can give polysaccharide vaccine because they are adults, they usually already develop some immunity against this pathogen by that time, So that is the reason. Don't forget it. Now, we have to give conjugate pneumococcal vaccine, conjugate meningococcal vaccine, and other routine vaccines, whatever, we have been giving to the child. Don't forget that. Don't ignore those vaccines like influenza shot. Every year, we have to give the influenza vaccines to the people. We also have to take every year influenza shot if you want to protect yourself from influenza. So that is also important here. From the age of 2 months, okay, from the age of 2 months, now see there, what should we do? Penicillin prophylaxis is given till 5 years or even later because the child is immunocompromised because of splenic dysfunction. And if we have not vaccinated properly, then penicillin prophylaxis has to be provided. But if the child has received vaccination, then it is no more necessary. So it is the alternative for the vaccination. Now, which one is better? Which one is easier? Definitely vaccination, okay? But vaccination is given a different time, isn't it? For example, if that time has not come yet, then I need to go for penicillin prophylaxis. When vaccines takes over, when there is a good amount of antibody formation, I can discontinue this prophylactic antibiotic. This is the meaning. Folate prophylaxis is necessary. This is a hemolysis. Bone marrow is hyperactive. It needs folic acid for the synthesis of new RBC. That is the reason. And we need to do early workup of febrile children and use of early antibiotics. Now, let me clarify this. See there? What does that mean? If a child with sickle cell anemia develops fever, if the child with sickle cell anemia develops fever, don't take it lightly. Take it very seriously until proven otherwise. What does that mean? I will consider bacterial fever or bacterial infection in a child with sickle cell anemia until proven otherwise. So how can I prove this is a bacterial infection? I need to do investigation. I need to go for CVC. I need to go for blood culture, chest x-ray, urine routine examination and culture, and if necessary, I need to go for bone marrow aspiration as well. So try to find out which infection is there and go for the early antibiotic. Do not wait. Do not keep the child under observation, because if the child is really having sickle cell disease, this child is severely immunocompromised, and in no time, the child develops septic shock. Okay, so this is a very important point. The same type of explanation you can give in other causes of immunodeficiency also. So see here, now let's come to the slide. Admit all children with any physical finding, high fever, and previous episodes of sepsis or splenectomy in a case of sickle cell anemia. Do not ignore them because they can die quickly because of fatal infection or sepsis. Another part is a pain treatment. A lot of painful crisis or painful episode occur in this condition. So we treat the child with some analgesics. One of the form of the analgesic is codeine, which is mixed with paracetamol. Okay, codeine with acetaminophen is paracetamol. This is a good combination. And another is we mix NSAID with opioid also. Now, another type of management is the blood transfusion. Blood transfusion, especially it is given in severe types of anemia and in certain serious clinical feature. Now, what are the indications? If a child is having acute chest syndrome, if the child is already having stroke, severe anemia, before any surgery in case of sickle cell disease, or chronic pain syndrome in some of the patient, we have to go for blood transfusion, because increasing that normal type of hemoglobin or normal type of RBC will help that patient, because this patient is having sickle cell hemoglobin. Okay, we replace that, or we dilute the amount of that sickle cell hemoglobin by giving normal blood. That may help the patient. Okay, but it doesn't last longer. Remember, those RBC which you have given from outside have also certain lifeline. So after that, again the same situation, recur. So this is not a permanent type of treatment. This is just a symptomatic treatment. One of the important drug which we can give in this condition is known as hydroxyurea. This hydroxyurea is a type of anti-cancer drug actually. Okay? Anti-cancer drug. It can be used in the treatment of chronic myeloid leukemia as well. So we do not know the exact mechanism, but this hydroxyurea increases the level of hemoglobin F in this case. Now I'm going to ask you one simple question here. Is this good if hemoglobin F replaces hemoglobin S in this case? Is it good or not for the child?
No. It will be.
Yes, please, I'm listening. Go ahead. Okay, this is a bit of difficult question probably, so let me answer this. Now see this, you have to compare which hemoglobin is better here. Hemoglobin F is definitely better than hemoglobin S in this case. I'm not comparing between hemoglobin F and hemoglobin A here, okay? I am comparing between hemoglobin S and hemoglobin F. Hemoglobin F will readily bind with oxygen, but a bit of problem, it doesn't allow easy unloading of the oxygen to the tissue. But still, in comparison, this is far, far better than hemoglobin S, because it doesn't polymerize, it doesn't obstruct our capillaries, it doesn't occlude the blood vessels. That's why still this type of therapy is considered better than doing nothing. Okay, but it may not help some of the patient. Now, the definitive treatment here, in this case, is a bone marrow transplantation. This is a definitive therapy. But there are a lot of fallacy or complication associated with bone marrow transplantation. You all know that. Number one, it is expensive type of therapy or treatment. All of the patient cannot afford it. It is very expensive therapy. Number two, okay, all the hospitals may not do it, okay, in that particular city or in that particular area. Number three, after doing bone marrow transplantation, the child has to be given immunosuppressive therapy for lifelong, and that is very expensive type of therapy, and the child may also be immunosuppressive. So because of all these things, our bone marrow may be rejected. That is another point. Because of this, bone marrow transplantation is not that very popular in case of sickle cell disease treatment. Yes, it is one of the options, we all know, but it is not very popularly done. What then? Okay, now remember what I told you in the pathophysiology. Prevent from dehydration, prevent from sepsis, or prevent from hypoxic episode. The child may live normal life if we remember these things. And if the child develops some problem, we are going to treat it symptomatically. Now, after doing sickle cell disease or sickle cell anemia, let's talk about another very important types of hemolytic anemia, that is thalassemia. Okay, thalassemia. Now, what is this thalassemia? What is the importance of this? What are the clinical feature? What is the genetic basis behind it? What are the complications? And how do we manage it? Okay, so this topic will cover all of that. Thalassemia is the most common genetic disorder on a worldwide basis. It is very common all over the world, but especially in South Asia, it is absolutely common. All the countries of South Asia are having excessive cases of thalassemia, especially beta thalassemia. Worldwide, 3% of the population carry the gene for beta thalassemia. That is a very high percentage. Now, in thalassemia, the key feature is globin chain imbalance with ineffective erythropoiesis. Now, if somebody asks you what is thalassemia, you can answer like this. Thalassemia is a genetic disorder where there is globin chain imbalance. Okay, globin chain imbalance or decreased synthesis of globin chain. There are different types of thalassemia. Now, what are the different types of hemoglobin? Accordingly, thalassemia can also be of different types. Remember that. Now, what are those? Isn't it? So, if we talk about fetal hemoglobin, there is 2 alpha and 2 gamma. If we talk about hemoglobin A2, there are 2 alpha and 2 delta. And if we talk about hemoglobin A, there are 2 alpha and 2 beta. All of these are globin chain. So we can have alpha thalassemia, we can have beta thalassemia, we can have gamma thalassemia, and we can have delta thalassemia. Okay, theoretically there is a possibility, but practically alpha thalassemia and beta thalassemia are only talked, okay, in the clinical practice because they are common, especially the beta thalassemia. Now, another term which is coming here is called ineffective erythropoiesis. What is the meaning of this? The meaning is, we have already talked about this before. The meaning is RBCs are getting synthesized, okay, in the bone marrow, but those RBCs are faulty one. So immediately after they're synthesized, they are getting destroyed inside the bone marrow itself. Okay, they are getting destroyed inside the bone marrow. So what will happen now? There is a chance of severe anemia. This is known as ineffective erythropoiesis. It doesn't occur only in thalassemia though, it occurs in megaloblastic anemia also sometimes. Now the common type of thalassemia are beta thalassemia and alpha thalassemia. Let's move on. Now, thalassemia is a type of genetic disorder. So what type of inheritance is there in thalassemia? The answer is very easy. This is autosomal recessive inheritance. Okay, autosomal recessive. Now see there, why it is autosomal recessive, you need to identify by looking at this flow chart. Autosomal recessive. Look here very carefully. Okay, parents, okay, father and the mother. Now see there, what are the possibility? What is the affected gene or abnormal gene and what is the normal gene? Let's find out here first. The red one is a normal gene and the green one is a thalassemia gene. Now, if you know that, you just match between the gene from the father and gene from the mother. Now, if this red, okay, if this red it matches with this red, then both are red, means both have a normal gene. So this is a normal baby. This is a normal baby. If red, okay, and green occurs together, this is the carrier one. So we call it thalassemia trait. Okay, trait is a carrier. One abnormal gene, another normal gene. The third possibility, see here, this is the third possibility. Again, this is a thalassemia trait. And the fourth possibility is both abnormal gene from each of the parents, okay, is coming together, and this is a diseased child. This child, okay, will have severe features of thalassemia. And this is known as autosomal recessive disorder. So if we talk a bit of theoretically, then 25% chance of having abnormal baby. Look at this. This is 25% chance. 1, 2, 3, 4. There are 4 possibility. Out of that, 1 possibility is of severe thalassemia. So 25% chance of having abnormal baby, and 50% chance of having carrier, and 25% chance of having normal baby. But this is in every pregnancy. Okay, in every pregnancy. It is not like in the family there are 4 child, and out of them 1 child is having severe thalassemia, other 2 child are having thalassemia trait, and the 4th child is normal. It is not like that. Please remember this. Many of the students have this type of misconception. Okay. Now the first thing here is every pregnancy there is a risk of, okay, this type of possibility. All the baby may be having severe thalassemia, or all the baby may be normal, or babies may be carrier as well. Now another important point here. That's why, okay, consanguineous marriage is one of the important risk factor of autosomal recessive disorder. Consanguineous marriage means marriage between very close relative, because they may be carrying the same gene from their, ancestors. Okay, and these genes combine together to give rise to thalassemia child. So consanguineous marriage history should be asked if you are taking care of this type of patient. Let's move on. Now with this, discussion, let's move on to the beta thalassemia topic, which is a very important one. Now, you already know what's a problem here. There is no synthesis of beta chain, or very decreased synthesis of beta chain. Why I am using those 2 terms? If this is, a homozygous state, because this is a recessive disorder, so we always talk like that: homozygous or heterozygous state. Heterozygous is the carrier state. Homozygous is the disease state. So if it is a disease, okay, homozygous state, there's no synthesis of beta chain. Only alpha chains are there. That is a quite abnormal type of hemoglobin. On the other hand, if it is a carrier state or heterozygous state, some amount of beta chain is going to form, but that is not enough. Let's talk about it. So there are no beta chain here. So there is formation of alpha 4 tetramer, which form inclusion inside the RBC. Okay, and these inclusion bodies or inclusion particle, they interact with the RBC membrane, and then that RBC membrane will become very rigid. That will lead to decreased RBC survival by causing lysis of the RBC, or our immune cells will remove this defective RBC. So this is the main pathophysiology of thalassemia. So let me repeat again. In beta thalassemia measure, there is no beta chain. So there is a formation of only alpha chain. 4 alpha will combine together to form 4. This is known as tetramer. Okay, 4 alpha chain together. It forms like a clump or inclusion body inside the cell. Now, this is abnormal particle inside the cell. So our immune system will identify those abnormal RBC and it will be removed from the circulation, okay, leading to anemia. So it causes anemia, and at the same time, bone marrow is trying to replace those RBC, but remember, those RBCs are also defective, okay, because this is a genetic condition. And over the process, erythroid hyperplasia of the bone marrow occurs, but immediately after these RBCs are formed, they are removed by bone marrow itself. This is known as ineffective erythropoiesis. But having hemolytic anemia, this is the important feature, erythroid hyperplasia. If you examine for fetal hemoglobin, it is very high. And if you examine for hemoglobin A2, it is also high. So this is the fetal hemoglobin, alpha 2, gamma 2, and this is the hemoglobin A2, a type of hemoglobin, alpha 2, delta 2. Now why these hemoglobins are higher? Okay, that question must come to your mind. Now remember, We are talking about beta thalassemia. So beta chains are not forming. If beta chains are not formed, hemoglobin A is not going to form. So we should have some other types of hemoglobin in place of that. And these are fetal hemoglobin and hemoglobin A2. So that's why they are formed. Now, all of you, please focus on this flowchart again. This is very, very important one if you try to understand this topic. So this is blocked beta chain synthesis in case of beta thalassemia. After that, there will be excess of alpha chain. Okay, this is a relative thing, isn't it? If beta chain is absent, only alpha chains are there. It will form alpha tetramer. This is 4 alpha chain. And this alpha tetramer will form inclusion body inside the RBC. These RBCs are the defective RBC. So they will be removed from the circulation, resulting in hemolysis. They're destroyed, hemolysis. This gives rise to anemia. This is a hemolytic anemia. What type of anemia is this according to the classification? Yes. What type of anemia?
Hemolytic anemia.
Good. Yes, that is hemolytic anemia. But remember another classification. Is it microcytic hypochromic? Is it normocytic normochromic? Or is it macrocytic? Which one? Which one?
Microcytic.
Exactly. Don't forget that. It is a microcytic hypochromic type of anemia. Microcytic hypochromic. This is one of the important feature of thalassemia, or beta thalassemia. Now, to treat this anemia, okay, this is a severe type of anemia. So we give blood transfusion here. Every month, the blood transfusion should be given. This blood has a lot of iron there. This iron will gradually accumulate in the body, okay, which is known as iron overload. And we have got a different term for this. This is known as hemochromatosis. Let me write it here, hemochromatosis. Now, hemochromatosis are of two types, primary and secondary. Primary is again a genetic disorder, but this is a secondary type of hemochromatosis, which is there because of different mechanisms like excessive transfusion, because of increased absorption of the iron from the GI tract, okay, those type of causes. So we call it secondary hemochromatosis here. Now, this iron, okay, being a type of metal, will be deposited in different organs. The important organs are heart, okay, endocrine organs, heart and endocrine organs. Now, heart can fail, okay, liver is another one. So liver will also suffer from some irreversible, reaction that is known as cirrhosis of the liver. Heart failure can occur, that is congestive cardiac failure. Pancreas gland may not function well, resulting in pancreatic failure. It can result in diabetes mellitus. Okay, this is the secondary type of diabetes, of course. And then the exocrine functions of the pancreas may also be affected here, but mainly the endocrine one. Gonads are damaged. Pituitary gland can become affected. Thyroid gland can become affected. So these are the different problem of hemochromatosis. Now let's go to the other part here. If hemoglobin A is not formed, then hemoglobin F and hemoglobin A2 are formed. Now hemoglobin F, okay, is having some problem in comparison to hemoglobin A, and that is increased oxygen affinity, but it doesn't give oxygen easily to the tissue. Now, what does that mean? The tissue still suffer from hypoxia, even if there is excessive hemoglobin F. That hypoxic environment will lead to release of erythropoietin. Erythropoietin will cause excessive erythropoiesis in the bone marrow. So the bone marrow, okay, is expanding, or the medullary cavity is expanding. And because of this, different skeletal anomaly can happen. And the most important part which we examine that is in the face and the skull. Face and the skull. there is definite abnormality which is seen. That is known as thalassemic facies. Thalassemic or hemolytic phase. Okay, facies is the common term we use. Okay, we'll talk about that a bit later. And other long bones are also affected. The medullary cavity of those long bones are also expanded, and then cortex of the bone will become thinner. So there may be easy fractures in those bones. So these are the problem of skeletal anomaly. Now, remember, whenever there is hemolytic anemia, spleen is the organ which removes or destroys those RBC, the affected RBC. So along with that process, spleen will enlarge in size. This is splenomegaly. Okay, so these are some of the important features. So let us move further. We'll again talk about this in the next slide. Now see there, all of you please focus once again. This is even better than the slide which we seen recently, but most of the things are similar. So let me clarify this again, because this is a very, very important concept for you. So all of the students please focus here. This is a normal erythroblast which will develop into the mature red blood cell later. So this hemoglobin A, okay, 2 alpha and 2 beta. And this is how the mature RBC looks like, biconcave in shape. When beta globin chain is formed in a decreased amount, there is excess of alpha globin chain, and this leads to alpha tetramer formation inside the hemoglobin or RBC, and this becomes the abnormal erythroblast now. Okay, we are talking about the erythroblast, which is a very immature type of RBC, is still present inside the bone marrow. Now, because this is abnormal, so the bone marrow itself will remove them from the circulation, or from the bone marrow itself. This is known as ineffective erythropoiesis. So most erythroblasts, they die in bone marrow, ineffective erythropoiesis. Whatever RBC, okay, or immature RBC come out in the circulation, they may become mature, but they are also defective. Definitely, they are also defective. So the spleen and other reticuloendothelial system will remove them from the circulation. So because of both of these mechanisms, severe anemia occurs in the child. Now, what are the related process or mechanism because of this? This anemia results in tissue anoxia or tissue hypoxia, you can say, which causes increased erythropoietin release. This will cause marrow expansion, clearly shown in the picture. See this, the marrow is expanded, but at the same time, the cortex is getting thinner in the long bone, okay? But in the skull, this is a flat bone, so skull has got inner plate and outer plate, and this space between them is very expanded in case of skull. And the facial bones also expanded, which gives rise to a typical appearance, which is known as hemolytic or thalassemic facies. We give blood transfusion repeatedly for the treatment of this anemia. And this blood has a lot of iron, which results in secondary hemochromatosis. You all know that. And without giving this blood transfusion, the child is going to die because, okay, there is no synthesis or no survival of RBC for a longer time in this child. Now, one more thing, there is increased absorption of dietary iron from the GI tract. Now, if you remember, I've already explained this mechanism before. Anybody remember that? Why there is increased absorption of dietary iron in this case? Why?
So because due to compensatory mechanism, because there is an increased production of RBC, and due to compensate the hypoxia.
Okay, okay. To compensate for the hypoxia. That is the correct answer. To compensate for hypoxia. Now see this. What is happening? This is a case of anemia. This is a case of anemia. Anemia means there is decreased hemoglobin or decreased RBC. Okay, mass. So the overall body feels hypoxic environment everywhere. So the GI tract we'll also have a type of compensation mechanism regarding this. And that is the GI tract, if the GI tract absorbs more iron, it helps in the synthesis of more RBC, okay, and that will help in the reversal of anemia. So that type of mechanism is going on in the body. As a result of this, even if there is excessive iron deposition in the body, still the iron is excessively absorbed from the GI tract. Now, this is not a good situation here. It will further aggravate the iron overload condition in the body. Okay, so if your teacher asks, what are the causes of iron overload? Please mention these two things. Repeated blood transfusion is one of them, and second, excessive iron absorption from the GI tract. So all of these are different problems in thalassemia major. Now with this, now let's talk about some other parts like a clinical feature, complication, and management. Now, beta thalassemia major children become symptomatic from 6 months of life only. They do not manifest before that. What is the reason? Anyone? What is the reason?
Because of the hemoglobin F, sir. In early life, hemoglobin F is present.
Yes, sir.
Excellent. Very good answer. Okay, precise answer you have given, and that is the correct one. Hemoglobin F is still there till 6 months of life. After that, it drastically decreases, and hemoglobin F, okay, will not allow the symptoms to appear before 6 months of life. Only after that, hemoglobin disappear, and hemoglobin A is the only remaining hemoglobin which is not formed here. Then the child becomes symptomatic. So transfusion necessary in first 2 months to first 2 years, depending on the amount of fetal hemoglobin. Now, though fetal hemoglobin is there, remember this fetal hemoglobin is not good for that baby. We all know that. It has got some fallacy. Okay, it doesn't allow unloading of the oxygen easily to the tissues. So still some of the babies may manifest a little bit earlier. That's why the first 2 months is written. Still, the majority of the children, they don't manifest prior to 6 months. And transfusion may be necessary right from this age, and it will be continued throughout the life till the definitive treatment is given. Let's move on. Now, all of you, please focus here. What are the signs and symptoms of beta thalassemia major? Beta thalassemia major is also known as Cooley's anemia. In some of the textbook, it is written Cooley's anemia. Okay. Now let me write that term for you. Cooley's anemia. So don't get confused. Sometimes the MCQ question may come like that. So now let's come back to the slide. Due to hemolytic anemia, these are the clinical features: pallor, jaundice, fatigability, poor appetite or anorexia, and lethargy. These are quite common. Now, why hemolytic anemia occurs? Because of abnormal, hemoglobin synthesis. And these hemoglobins are destroyed by two ways. Let me repeat again. One, by ineffective erythropoiesis, which occurs inside the bone marrow, and another one outside the bone marrow, mainly in the spleen and reticuloendothelial system. Now, why jaundice occurs here? Any answer? Why jaundice occurs?
Sir, because sir, we have hemolysis, sir, sir, to do is
Because
there is
the excessive hemolysis.
and so this
Exactly.
hyperbilirubinemia will cause the jaundice.
Exactly. You can simply say because of the hemolysis, your teacher will understand. Okay, because of hemolysis, the heme component will form bilirubin, and hyperbilirubinemia leads to jaundice. This is unconjugated type of bilirubin. So this jaundice is not very severe type of jaundice. The child just looks a bit yellow here. Okay. Now, another important feature is the thalassemic facies. This is abnormal face or facial appearance because of expansion of the facial bone, because of the expansion of the frontal bone in case of skull, because of the abnormal configuration of the teeth, especially in maxilla. A typical facial appearance occur This is known as thalassemic phase. Pathological fractures are also quite common, especially in the long bone, because they are also suffering. There is expansion of the medullary cavity, but there is thinning of the cortex. So fracture can occur. Remember the meaning of pathological fractures. The bones are already abnormal. They are no more normal bone. So even with a trivial or small type of injury, the bone can be fractured. Hepatosplenomegaly, very important clinical feature. Without liver and spleen enlargement, the diagnosis of thalassemia is in doubt. Remember this, spleen is hugely enlarged than the liver. The liver is also affected. And the reason for this, okay, are one is destruction, which is going on inside both of these organs, mainly in the spleen, but liver is also having Kupffer cell. These are part of the reticuloendothelial system. So they also contribute in the destruction of the RBC. Another point, there is formation of RBC outside the bone marrow. This is known as extramedullary hematopoiesis. Very good. Extramedullary hematopoiesis. So because of this, okay, because of this mechanism, there is enlargement of the liver and spleen. So you can give these different reasons here. And the child is very anorexic. Okay. The child is losing appetite for a long time. So this leads to cachexia. Yes, please.
Uh, so, sir, regarding hepatosplenomegaly, sir, can we also give the reason of because of iron overload? It can also cause hepatomegaly, sir, iron overload.
Exactly. Of course, you can give. Very good. That's the third reason you can give. Absolutely. But remember, in the early cases only, there is hepatomegaly. Later on, when the cirrhosis of the liver develops, there is shrinkage of the liver. Okay. So if you are mentioning like that, the examiner will definitely catch you and ask this question. Do you really think in cirrhosis also there is hepatomegaly? The question may comes like that. So you need to, defend your answer there. Now, another one is cachexia. Cachexia means extreme thinning, okay, extreme loss of weight. And there are multiple reasons for this. One is anorexia because of hypoxia. Another is hypoxia itself. Whenever there is hypoxia all over the body because of severe anemia, the energy cannot be utilized there. The energy production is a faulty there, resulting in severe loss of weight. So let's move on. Now, because of ineffective erythropoiesis, these are the feature you can see. Okay. And the features are massive expansion of the marrow of face and skull, which we can see very easily. Extramedullary hematopoiesis, because bone marrow is quickly, destroying those RBC, and that's why, as a compensation mechanism, spleen and liver are forming the RBC, and there is a huge caloric need of the child, of the patient. Huge caloric need. This is a hypermetabolic state. A lot of destruction is going on. A lot of synthesis is going on in the bone marrow. The child needs more calorie, more energy. But because of anorexia, because of hypoxia, that is not happening. That's why there is a lot of weight loss. Look at this picture here. This is a very, popular or famous picture, I should say. And, many of the textbooks are also having this one. You see this? Look at the face here first. These are the teeth, which are quite prominent in this child. Okay, these are the upper teeth. Okay, these are attached with the maxilla, and there is, expansion of the frontal bone. Look at the forehead. Okay, forehead is quite prominent, and because of this expansion of the forehead, okay, the base of the nose looks a bit of depressed here. Okay, and another one, all these maxillary bones are expanding. So typical type of face is seen. You should never forget this once you see this type of picture. That the child, when this child comes in front of you, you can clearly say, yes, this face looks abnormal. And that thing, suddenly comes in your mind. Can it be thalassemia or not? and you look for some other features like severe pallor. This child is maybe a paper white in appearance. Okay, a bit of jaundice may be there. Hepatosplenomegaly may be there. The child, who knows, the child may be having pathological fractures. So these are the things. Now look at this child abdomen. Okay, here is hepatosplenomegaly, which can be seen from outside also, though it is a bit of marked here. But even without marking, there is abdominal distension, and the cause of this abdominal distension in this case is organomegaly, hepatosplenomegaly. Okay, this is important one. Now, another important point is the expansion of bone marrow. Expansion of bone marrow of the skull. Now, see this. If we take the X-ray of the skull, it looks like this. This is known as crew-cut skull. Crew-cut skull, just like a army personnel. It looks like their hairstyle actually. Now, why is this? Because of the expansion of this, the middle part. This is a outer plate of the skull bone. This is the inner plate, and this is called diploid space. Diploid space. So diploid space is expanded, and it exactly looks like this in the X-ray. This is one of the very important X-ray which will be shown to you in your future exam. Please do not forget. This clearly tells us this is a case of thalassemia, and this is a pathological specimen. Look how expanded it is. Okay, this is a diploid. This is a internal plate, external plate of the skull. Now, what are the features of iron overload? Though many of the important points I've already told you. In the liver, the iron is deposited and it may cause fibrosis and cirrhosis in the long run. Cirrhosis is called terminal stage of the liver disease. And after that, the condition is irreversible. Beta cells of the pancreas are damaged because of the deposition of iron, which leads to diabetes mellitus. This is secondary diabetes. Okay, secondary diabetes, also known as bronze diabetes. Bronze. See there. Now, the meaning of bronze diabetes is it is seen in hemochromatosis. Hemochromatosis. And this is one of the conditions where hemochromatosis occurs. Though this is a secondary hemochromatosis, but it occurs in this situation because of excessive, blood transfusion. So the skin is also looking a bit of brownish, okay, a brownish or bronze type of appearance. At the same time, because of damage of the beta cells of the pancreas, the person is having diabetes. So when we combine these two things together, this is known as bronze diabetes. Important MCQ question in the exam. Very commonly occurs in primary hemochromatosis than in the secondary. Pituitary, okay, pituitary gland, testes and ovary, these are the gonad, may be affected, results in retardation of the growth, hypogonadotrophic hypogonadism may occur. This is the damage of the gonad. Parathyroid gland may be damaged, resulting in hypocalcemia. You all know the mechanism, because parathyroid hormone is lacking now or decreased, and the function of parathyroid hormone is maintaining the calcium level. So it results in hypocalcemia here. In the heart, okay, the heart may fail. The heart may develop arrhythmia, okay, because of the enlargement. Myocarditis may happen, so some murmur can occur there. So all these things can happen in case of heart. And usually the child with beta thalassemia die because of cardiac complication. Okay, they die because of cardiac complication, like serious arrhythmia, myocarditis, intractable heart failure. Intractable means very difficult to treat by medical management. The child may collapse or die. And these are the mechanism of damage. The free iron can catalyze the formation of injurious compound like hydroxyl radical, superoxide anion, and these are called oxygen radical. And this hydroxyl radical or other oxygen radical are highly reactive, and they can attack lipids, proteins, and DNA, which are present in our cell, resulting in different organ damage. So this is the basic mechanism. Now, what are the lab findings of thalassemia measure or beta thalassemia measure? Another important part of this lecture. So regarding this lab finding, first is you go for CBC, and CBC will show you anemia because of decreased hemoglobin. Okay, there's no doubt about it. This anemia is usually very severe type of anemia. Peripheral smear is always done in this type of cases, and this will show microcytosis with hypochromic anemia. Definitely, microcytic hypochromic anemia. Anisocytosis, poikilocytosis, nucleated red cell, and leukocytosis with few reticulocytes are also seen. Now, a little bit of explanation is necessary here for the student. Till this numerous nucleated red cell, it is very easy for you to understand. But why is there leukocytosis? And why there are very few reticulocytes in comparison to other types of hemolytic anemia where reticulocyte count is very high? For example, in sickle cell anemia, the retics count is around 5 to 15%. But in this case, it is not higher like that. It may be slightly, 2 to 3% maybe. What is the reason why retics count are not that high in this case? Anyone? Anybody?
Because sir, maybe in reticulocytes are the mature cells, and in hemolysis they break down of these cells in hemolysis.
Okay. Okay, good. That is one of
Basically,
the.
sir,
Uh-huh.
basically, sir, we had a point, sir, sir, we had a point that decreased erythropoiesis in thalassemia, and so due to this decreased erythropoiesis, we have the decreased reticulocytes, sir. Because sir, earlier we read about that impaired impaired erythropoiesis, sir.
Okay, fine, fine, fine. Now, all of you, please listen here properly. This is because of ineffective erythropoiesis. Erythropoiesis is occurring there. There's no doubt. It is occurring in a still increased rate, but those erythrocytes are quickly dying. Okay, reticulocyte is also developed from those young erythroblast. So that's why the reticulocyte count is not very high in comparison to other types of hemolytic anemia. Cytosis occurs because of lab error actually. That is the most important reason. All those nucleated red cells, they are counted as the leukocyte in many labs, especially if it is done by some unexperienced, lab personnel. This is clearly written as one of the cause in different textbook. And another one, probably this is a bit of, hypoxic situation, isn't it? Hypoxic situation is a stressful situation for our body. And because of a stressful condition, there is usually migration of leukocyte from the margin of the blood vessels to the mainstream. That may be another cause of leukocytosis. Now, in the later on stages, what happens? Because of the massive enlargement of the spleen will develop hypersplenism. Now, let me write that term for you. Hypersplenism. You have already heard this term before. As a result of hypersplenism, there is consumption, or destruction of even the normal blood cells that may result in leukopenia later on, rather than leukocytosis. So it depends according to the situation. Okay, so let's move on. Another, important investigation in case of thalassemia measure is hemoglobin electrophoresis. This is very important type of investigation, just like in the diagnosis of sickle cell anemia. Okay, this is probably the most important investigation for the diagnosis. And we may see hemoglobin F as a 98% and hemoglobin A2 as 2% with absent of hemoglobin A in case of beta thalassemia measure or Cooley's anemia. This is an important, point here. Now, reason I've already explained to you why this happens. Okay, because of failure of the beta chain synthesis, the hemoglobin will, form as the alternative form, that is hemoglobin F and hemoglobin A2. Serum iron and serum ferritin levels are increased. Now, because of excessive iron overload and because of increased storage from the iron, this is increased. But iron binding capacity or total iron binding capacity is decreased. Exactly opposite of iron deficiency anemia. Every student know that. If you do bone marrow aspiration or bone marrow analysis, there is erythroid hyperplasia and there is increased iron store because of overload condition. Let's move on. Now look at this peripheral smear here. Okay, these are the polychromasia, different types of color. Okay, poikilocytes and isocyte. They're different things, a bit similar to the other types of hemolytic anemias. Okay, and most of these cells are microcytic hypochromic cell. This is the classical hair on end appearance and plain skull radiograph of a patient with thalassemia major. This is a very important, X-ray. We have already seen it before. So this type of questions are very commonly asked in a computer-based exam these days. Okay, they may give a clinical scenario to you, show this type of picture, and ask the question. Don't get confused. Now the final part: what is the treatment of beta thalassemia major? How we are, managing this type of case? Now the management can be discussed under two headings. One is symptomatic and supportive therapy. Another is definitive therapy. Now, according to the symptomatic and supportive therapy, we need to give blood transfusion. Blood transfusion every month. And the goal is to maintain the hemoglobin level at around 9.5 gram per deciliter. Now, let me clarify, okay? Please listen properly. I will give a lot of, explanation here. Now, 9.5 gram per deciliter is still in the anemic range, according to our definition of anemia. So that question must come in your mind. Why we are still maintaining the hemoglobin in the anemic range? And the reason for this is to avoid iron overload. If you are enthusiastic and give a lot of hemoglobin, that will carry more iron inside the body of the child. And that is more damaging for the child rather than maintaining hemoglobin slightly on the anemic side. Okay, so this is the reason. And this is enough for our cells to get a good amount of oxygen. Because of iron overload, we have to go for iron chelation therapy with deferoxamine and deferriprone. Desferoxamine and deferoxamine both are the correct spelling because both are equally used in different textbook. So this is given in the subcutaneous route. Deferoxamine subcutaneous infusion is given, and this will bind with the free iron, and that iron will convert it into water soluble form, and then it is excreted from the kidney. This is called iron chelation therapy. Deferriprone is the oral medicine. Okay, oral medicine. It is slightly hepatotoxic than deferoxamine. Folic acid is given, already know the reason. This is a type of hemolytic anemia. Bone marrow is, hyperfunctioning here. The definitive treatment in this case is hematopoietic stem cell transplantation. This is known as bone marrow transplantation. It is just another term. This is the definitive therapy. And as far as possible, we should always promote this type of therapy quite early in life before that child gets a lot of blood transfusion. Okay, then there is a high chance of successful or success of this type of therapy. Now, one question: who is the donor of this bone marrow? Who is the appropriate donor? Yes, who donates this bone marrow? Anybody?
After doing the blood typing and blood matching.
Good. Okay, good, Junaid. Anybody else?
Sir, basically, sir, we match the hemoglobin, sir, because there is that absence of that beta chain. So we'll match those with the same hemoglobin. Then we will do that everything, sir. Majority.
Any other answer? Anybody else? Yes. I want to listen some more answer here. Anybody? My question is, who are the best donor? That is the question. Now,
Family member.
okay, so let me answer this. Somebody is saying family member. Okay, good. So here, please listen properly. Siblings are the best donor. Siblings, not father, not mother, brother and sisters. They are the best donor of the bone marrow or any of the organ. Okay, whatever you want to donate, because of a high chance of matching of the HLA. So before we go for the transplantation, HLA typing and blood grouping. These are the two important things: HLA typing and blood grouping. Now, among the siblings, okay, there is 30% chance of matching between the bone marrow. So that's why you usually go for the siblings, and so, sometimes even higher than that. But if siblings are not there, then you have to find the bone marrow. You have to do this typing, and whoever is matched, then you can give bone marrow from that person. Now, bone marrow transplantation is just given like a blood transfusion, just like a blood transfusion. This bone marrow is a substance which is present inside the medullary cavity of the bone, very commonly found in the flat bone. So they take a bit of bone marrow and then give it into the patient just like blood transfusion. But remember, before you transplant bone marrow, the bone marrow which is present in that patient should be destroyed completely. Okay, then only the new bone marrow will be taken by that patient. Now think about situation here. Please listen properly. This is a very important concept. After we kill all the bone marrow and the blood cells, the person will be severely immunocompromised for that duration. And we must give good care of this patient. Okay, like broad spectrum antibiotics are necessary, antiviral, antifungal drug, all those symptomatic management, a lot of RBC transfusion or packed cell transfusion, platelet transfusion, even leukocyte transfusion. Everything has to be given in a best center. And that's why this treatment is very expensive. And many of the people, they cannot even afford it, even though their kids need it. So before deciding for bone marrow, we need to think of all these aspects. Don't only, say, yes, your kid needs bone marrow, and if they cannot afford it, then what's the use of it? And even after the transplantation, remember, they need to take some immunosuppressive drug for the whole life. Okay, so there are lots of adversity associated with bone marrow transplantation. But having said that, this is a curative type of therapy in case of thalassemia. Now, another one is splenectomy. Splenectomy. It is removal of the spleen, because that spleen is the culprit here. That spleen is destroying or damaging the red cells. Whichever red cells are circulating in the blood, the spleen is removing them. And over a long period of time, the patient develops hypersplenism also. So even some of the normal cells which are forming can be destroyed. So splenectomy is indicated here. But what is the indication? Patient who require more than 200 to 250 ml per kg of packed red cell transfusion per year to maintain an hemoglobin level of 10 gram per deciliter are the fit patient for splenectomy. The splenectomy indicated in them. But let me remind you once again, before you decide for the splenectomy, proper vaccination has to be given, like pneumococcal vaccine, meningococcal vaccine, and vaccine against Haemophilus influenza type B. These are the must, along with other vaccine. And if you cannot vaccinate at this time, you have to give antibiotic prophylaxis, after the splenectomy. Okay, let's move on. Now, the last part of this important topic is screening and prevention of thalassemia. Is it possible or not? Yes, it is a possibility. Premarital screening with marriage counseling has to be done. Now, especially if some people are having consanguineous marriage, okay, before they do that type of marriage, premarital counseling has to be done and premarital screening has to be done, whether they are carrying the gene of thalassemia major or not. And we should advise against that type of marriage if they are carrying that gene. Otherwise, there is a 25% risk of having the affected baby, you know. And even if they are not having the affected baby, that baby may transmit this gene to the future offsprings because the baby may be a carrier. Genetic counseling of the parents with affected child is another important point. Now, the first child was born with beta thalassemia major, and they are worried the second child may also be born like that. So we diagnose it first, and if that baby is also having beta thalassemia major, we counsel them appropriately. We tell them what exactly is the situation, and they are the one who decide whether to continue that pregnancy or to abort that baby. It is not you who decide. Remember that. You don't say, oh, this baby is born with thalassemia major. What will you do with this baby? This is not the way of counseling. You say all the aspect, all the problems associated with thalassemia major. You give the available treatment options. Then the parents will decide on their own. And another one is a prenatal diagnosis. Now, how we do prenatal diagnosis? How? Yes? What are the different way of getting that sample? Remember obstetrics here? How we get the sample? Yes?
Amniocentesis.
Very good. Amniocentesis is one. Excellent. Another one?
Sir, chronic venous sampling, sir, CVS and photosynthesis.
CVS. Very good. CVS. Chorionic villus sampling. Very good. Chorionic villus sampling and amniocentesis. Amniocentesis. These are the two very important way of getting that fetal tissue. And after we get that fetal tissue, they will do some DNA analysis, and then they will find out whether the abnormal thalassemic gene is present there or not. Okay, so this is the way. And then again, genetic counseling will be given to the parents whether they want to continue this pregnancy or not. Now, lastly, I want to summarize some of the very important points. Please listen properly. This is a genetic disease. Okay, this is a genetic condition. So it may occur in the family. Some unfortunate family may have all the kids suffering from thalassemia, and some lucky family may not have any affected child, though they may be the carriers. So this is the first point. Second, this is a microcytic hypochromic type of hemolytic anemia. Third, there is massive splenomegaly as well as hepatomegaly in this case. There is expansion of the bone marrow, resulting in skeletal deformity, which manifests mainly as crew-cut skull if we take the X-ray or the normal X-ray of our skull, and thalassemic facies or hemolytic facies. At the same time, there may be pathological fracture. Another very important point is there is iron overload in this case. The reasons for that are mainly two. One, excessive blood transfusion, and second, excessive iron absorption from the GI tract. That iron deposition occurs in different tissues and organs of the body, resulting in damage. Okay, and that can be manifested as heart failure, arrhythmia, death of the child, and different endocrinological manifestation. And regarding the diagnosis, hemoglobin electrophoresis is the one which will give me the diagnosis. Apart from that, I can go for CBC and peripheral smear examination. Okay, and I can also go for iron profile study. There is excessive iron in the body in this case. Regarding the treatment, there are two types. There is, some type of symptomatic and supportive treatment. For example, if the child is anemic, we have to give RBC transfusion or Paxil transfusion. We all know that. Then another is iron overload condition is treated by iron chelating therapy like desferoxamine or deferiprone. Splenectomy can be done. And the most important definitive management here is a bone marrow transplantation, if the donor is available, if the family can afford for it. Okay, so this is all about beta thalassemia measure.